Ladies and gentlemen, I had the query because I didn't know what you are, your title is. Mr. or Doctor? And
Formally doctor, but we don't mind.
why not? Are you in?
Depends on person's choice. Depends on choice. Like Simon likes Mr.
It's interesting because of tradition for the other surgeons calling themselves Mr. It's almost like a downgrading in the eye of the public.
Yeah.
Yeah, it's weird. Can I just, on something totally unrelated, when you said the words to country, I belong to a group called College AGM, and we go into schools, all schools in Victoria, to talk about bullying and a whole range of things and how to avoid, how to help people to be an upstander. We call ourselves upstanders. It's really interesting, and we always do the things to country, but we say, why do we do this? You've heard it a million times, and because you've heard it so often, you probably ignore it. But it's about respect, isn't it? It really is respect, and I think it's so important. And I used to think, oh my God, I've heard this so often, but really it is important. It's interesting, the kids, the way they react to these things. Totally unrelated, but that's what I do a lot of now, going to schools and doing that sort of stuff. And telling them my story, because I was a Holocaust survivor, and that brings in, and I start off by saying, I shouldn't be here, and I really shouldn't be here. My children shouldn't be here, my grandchildren, and their children in the future. And I'm only here because of chance, partly, but more importantly, that ordinary people did extraordinary things to help people. That's what the whole program is about. The Holocaust is just used as an example, because of many others as well we mentioned. But it's just and we find the grade 5s and 6s so much more perceptive than say the year 10 or 11. Because they haven't developed the testosterone yet and the cynicism, and they're really fantastic. Sorry about that, it's just I've been so involved with it that I think. So this is a short talk, so it'll be a relief to know. And corticosteroids and pain, somebody suggested, I forget who it was, one of you lovely people suggested I should do that. I'm at your beck and call, you asked me not to. So we're looking at chemical structures again, of course, as you're aware. Hydrocortisone, prednisolone, and dexamethasone are the three most common ones that we use. And they've all got the cyclopentanophenotrate molecule. And here, as you can see, this F is for fluoro, a fluoro group, and that tends to give it more potency. And they have just slightly varying things. That we use prednisolone or prednisone in the same dose and everything. There's no clinical difference because prednisone is converted to prednisolone in the body. So if you're trying to decide which one. So inflammation and pain, we should probably start with, of course, and you're all aware of that. It happens, that's what a lot of people see you for. Acute inflammation causes pain of varying types and severity. It can be constant and steady, throbbing, pulsating, stabbing, or pinching. So that, again, when you ask people about the pain, can you describe the pain? Is it throbbing? Is it pinching? So, inflammation and pain then, we have a quick look. Nice pictures you don't have. And we went through this before. So, osteoarthritis, so I'll just skip through that. I did that in the pain bit. The corticosteroids. Corticosteroids reduce pain by reducing inflammation and edema associated with tumours, depolarization, damage to nerves, and so on. Dexamethasone is the most commonly used corticosteroid, owing to its lack of mineral corticoid effects, a long half-life and high potency compared with other corticosteroids. Corticosteroids work by altering the immune response, controlling inflammation, which can cause pain and decrease movement. You would see a lot of that. Corticosteroids may be taken in tablet form, applied topically to the skin, or injected directly into the tissues. And again, they can be used topically to the skin, mostly for their local effect, anti-inflammatory on the skin. For instance, if somebody is suffering from a tinea infection, and it's pretty bad, there's quite a bit of pain associated with it because of inflammation. And generally the treatment now is a topical sorry, but I've got to see in a moment. Would be a corticosteroid, it's usually prednisolone, in combination, or hydrocortisone, sorry, in combination with with an antifungal agent. And that's used for a short period of time to reduce inflammation, then you switch to just the antifungal agent. You don't continue on. Because once the inflammation's gone, then you're now having the effect of the antifungal. Now, it used to be thought you can't use an antifungal with a corticosteroid. Yes, you can. In fact, in some cases, you have to, an option. But that's just a topical issue. Now, corticosteroids tend to be used in the short term, although they can often be used by people who have chronic pain conditions and other conditions. People who are suffering from serious asthma. Some people, like my wife, is on 5 milligrams of prednisolone, has been for years and years, and as soon as we could drop to 4 milligrams, the symptoms become quite excessive. Sometimes we have it up to 37.5 milligrams and then drop down. Some people take it for chronic swelling of the joints and tendons. However, corticosteroids are more frequently used to treat flare-ups or episodes of acute pain associated with long-term conditions. So people tend to associate corticosteroids with inflammation, but they don't tend to go the next step, which of course inflammation creates pain. You reduce the inflammation, you reduce the pain. They may be used for this purpose in people who have the following conditions in order to increase pain, increase joint tissue mobility, and a whole bunch of those. They commonly use corticosteroids are betamethasone, that's usually in the skin, cortisone, dexamethasone, hydrocortisone, methylprednisolone, prednisolone or prednisone, same thing, triamcinolone, and that's the range that we've got. So if you look at prednisone, prednisone, for some reason, some prescribers like prednisone, other prednisone, it really doesn't matter because it's pretty much immediately within the liver, it's converted to the active ingredient, which is prednisolone. So having to just creates confusion in people's mind, saying which is more potent, they're not, does it say. The mode of action, corticosteroids regulate gene expression, which results in glucocorticoid effects, that is glucogenesis, proteolysis, lipolysis, suppression of inflammation and immune response. Those two last points are the more important ones. Mineralocorticoid effects such as hypertension, sodium and water retention, potassium loss. So that's the difference really between glucocorticoid action and mineralocorticoid action. We want to reduce the mineralocorticoid action, and the corticosteroids will vary in their ability to be mineralocorticoid or glucocorticoid, and you really want the glucocorticoid. Corticosteroids, they have predominantly glucocorticoid effects, dexamethasone, or mineralocorticoid effects, fluorocortisone, that should read, or a combination of both, such as hydrocortisone. The indications of the corticosteroids, generally speaking, they have a whole range of activities and indications, really. Used in pharmacological doses in a wide range of conditions for the anti-inflammatory and immunosuppressive effects. So that's where they use predominantly, but there are many, many conditions that produce those. Used in physiological doses as replacement therapy in adrenal insufficiency. You probably don't see that all that much. The precautions, there's quite a few associated with them, particularly if we're looking at longer term. Latent TB can be reactivated. Peptic ulcer disease may increase the risk of peptic ulcer. They're a bit like NSAIDs. They can have a similar effect within the gut. Diabetes, corticosteroids, including intra-articular injections, may cause hyperglycemia and worsen diabetes control. Hypertension and heart failure may be worsened due to sodium and water retention. That's where you'd have to be careful which corticosteroid you're using. Psychiatric disorders may be exacerbated, and some people, when they are taking corticosteroids, starting a dose for the first time, for some particular conditions that's creating pain through the inflammation, they tend to get quite hard. I'm free of pain, this is wonderful, it's a magic drug, I have to keep taking it. It's quite an amazing thing. Glaucoma, intraocular pressure may increase, osteoporosis. So my poor wife, who's been on corticosteroids now, 5 milligrams mostly, a long time, never had diabetes, now has diabetes, and she's also got, osteoporosis, but she's also got another one. Myasthenia gravis, increased muscle weakness may occur during the first few weeks of treatment with corticosteroids, and phagocytoma, and they can precipitate a crisis. So and I'm sure you all know, these are not benign things. They can be absolutely wonderful and have a magical effect, inverted commas, in people's well-being, but they also can have a lot of problems. Infection, corticosteroids suppress the immune system and can increase the risk of severity of infection. And that's why, for years and years, pharmacists were saying, oh, you can't use a corticosteroid with an antifungal agent together. Well, you can in the short term. Then once inflammation's gone, you then just treat the infection. And again, they can mask the signs of infection, so that's really important. Use caution in patients with a history of recurrent infections. The decision to start or continue corticosteroids in patients with infection depends on a number of factors: type of infection, including whether active or latent, its severity, whether the infection can be treated or controlled, and the indication for the drug. Specialist advice should be sought, in fact, sure, of course. Surgery, patients with hypothalamic pituitary adrenal or HPA suppression due to corticosteroids or taking replacement dose corticosteroids for adrenal insufficiency require corticosteroid protection against adrenal crisis during surgery and for 24 to 48 hours after. Wound healing may be delayed by pharmacological doses of corticosteroids. So I've cut myself, it's sore, I'm going to put a hydrocortisone cream on, which you can buy in the front. And that would be totally inappropriate if there's an infection there. Unless it's got the cover of the antibacterial, antifungal, whatever it might be. The children, chronic use of corticosteroids, pharmacological doses may retard growth, follow growth and development carefully, catch-up growth may occur after the corticosteroid is withdrawn. Pregnancy is considered safe to use as non-treatment may be more serious for the fetus and ongoing pregnancy. Use the lowest effective dose of the shortest possible time. That's a rule of thumb for therapeutics, but certainly it's probably much more important in some areas like this one than others. Hydrocortisone, prednisone, and methylprednisolone are preferred for maternal disorders, that's placental transfer is limited, whilst betamethasone and dexamethasone are preferred for fetal disorders, as placental transfer is greater. So again, you need to look, it's all based on the physicochemical nature of the drug, of the particular compound they're using. This is general, of course. Adverse effects occurs when corticosteroids are used at pharmacological doses rather than physiological replacement doses. Mostly we'd be talking pharmacological doses. Incidence of adverse effects is related to the dose and duration of treatment. So again, the minimum dose possible to achieve whatever you're trying to achieve, and of course the shortest duration possible. One of the things they now do, we used to have corticosteroids, so if you've got a flare-up or something, you take a high dose of the corticosteroid, so prednisolone, and then you gradually reduce it. Now they tend to think it's probably just as valid and probably more effective by keeping that high dose for 2 to 3 days and then just stopping. It used to be thought you can't stop suddenly. You have to weigh up. Either or is okay, but again, if you go for 10 days with high dose and then stop, then you could be in trouble. So if it's a matter of 3 days, you can stop suddenly, it's okay. So that's a practical point. Things change all the time with recommendations based on evidence, obviously. Be aware of the systemic effects may also result from inhaled, intra-articular and topical treatment. Again, we have a huge population of people with asthma and lung disease of various types taking inhaled corticosteroid, and whilst they're designed not to be absorbed to any great extent and get into circulation, some does. There's no question about it. Short course of high-dose systemic treatment cause fewer adverse effects than prolonged course at lower doses. So that's really the point I was making before. So it's really more beneficial to have a short course of a high-dose systemic treatment, it's oral treatment, say, with fewer adverse effects than prolonged course, even if you're going downhill.
Louis, what do you consider a short dose?
I'm sorry?
Short course.
3 to 4 days. Yeah. Adverse effects, they occur when done that. The common ones. Again, you can see there's a big list. I won't read through them. There's a whole lot of common. Remember, that is greater than 1% of people who are taking it. Now, of course, there'll be variations in doses and needs, but there's a whole bunch of things. But hypoglycemia, diabetes, dyslipidemia, osteoporosis. Again, people who are on long-term, even low doses, well, 5 milligrams, not that low, that my wife takes, and she's got 3 of those things. Induced, corticosteroid induced. And that is an issue. And we're desperately trying to reduce it, but you can't, because we can't control the breathing situation. Intra or periarticular injection, post-injection flare of pain, injection site, periarticular calcification, usually asymptomatic. The skin, subcutaneous tissue with atrophy in its injection site may be associated with hyperpigmentation. Also, applying corticosteroids to the skin for a long time and just using willy-nilly can cause the skin to thin. Now, as people age, their skin thins anyway, but with the addition to constant use of corticosteroid products, creams or ointments, the skin will get even thinner. And what happens is in some people, and again, my wife's a tragic example of that, if she were to do this, just that, not hard, just what I've done now, her skin would split open. And it invariably would become infected. So it really can have these effects. The infrequent ones are osteonecrosis, particularly some, the rare ones, and then you've got things like psychiatric effects, include euphoria because you're feeling so much better, hypomania, depression, disturbances of mood, cognition, sleep, and behavior. You wouldn't give them to anybody, would you? When it's a balance, isn't it? And that's what a lot of drug use is. It's a balance, trying to get more of the positive and less of the negative effect. It's just this has a lot. Comparative information. Differences in corticosteroids include their relative anti-inflammatory and sodium retention potency and the routes of administration. Where possible, use corticosteroids locally, such as inhaled, topical. Well, that's for perhaps not in your area so much. Cortisone and hydrocortisone are generally used for replacement therapy in adrenal insufficiency. Mineral corticoid replacement with fludrocortisone may be required. Corticosteroids at minimum mineral corticoid properties, such as prednisolone or prednisone, are generally preferred to use as immunosuppressants or anti-inflammatory agents. And this is just to give you some idea. Okay, you will be examined on this, you know that, don't you? Okay, that's all right. So there you've got the corticosteroids that we have. The routes of administration, I can use this, the routes of administration. The anti-inflammatory potency, which in most cases is what we're mostly concerned with. So you can see you need 25, the potency related, so that cortisone is much more, betamethasone is much more potent than cortisone. About the same as dexamethasone, and fludrocortisone is less, and so on. That's what that means. And again, there's a sodium retaining potency, and of course that's a good thing, none, in this case of betamethasone, very low with cortisone, none dexamethasone. Fludrocortisone isn't a big issue from that point of view. That can have dramatic effects. So this is one you want to avoid, except if it's indicated for that particular condition. So there's some notes about it there as well. Well, I did say it was short, but the other next two are not so short. Okay, so again, my love of chemical structures. I had a lecturer when I was doing pharmacy in chemistry, in the chemistry lecture, and this guy, this was the days of blackboards, but he didn't even use a blackboard. I remember he was describing a complex molecule, and he was holding his hands up, and I could visualize that molecule. It was amazing. And I could see, and the thing, this man was incredibly handsome, and all the girls, and they mostly failed because they're so busy looking at him, they weren't looking at the bottle.
Lots of chemicals.
Absolutely. Yeah, they've got a lot of chemicals being released today. Well, thank you. So I'll go straight on? Or,
Yeah.
Okay. Now, if you can help me to get onto that. Not having a mouse on that.
You okay?
No. Is this that one? I'm just oh, that's
Just starting again, guys.
okay. Ready to rock and roll? Now, a lot of the stuff you'll probably already know, and a lot of stuff I've done before, I'm sure you know. So it's a revision more than anything. Okay, thromboembolic prophylaxis. And the references I refer to are remarkably similar, in fact identical to the ones I had before. But there are other references as well. But certainly, Australian Medicine's Handbook, you may want the AMH Aged Care, which is the Australian Medicine Handbook Aged Care, but it's basically repetition, but dealing with the older people, probably not getting. The therapeutic guidelines, and I think it's really important, therapeutic guidelines, to realise that there are so many, and they are all now available. There's 15 of them now, and that's quite important. And then these others I won't go through, you've seen them before. So venous thromboembolism, VTE, also known as blood clots, is a disorder, includes deep vein thrombosis and pulmonary embolism. A deep vein of DVT occurs when a blood clot forms in deep vein, usually in the lower leg, thigh, pelvis. You treat some of those? Yeah, you would, of course you would. Anticoagulants, the treatment of venous thromboembolism. So that's an indication for the anticoagulants as groups. Prevention of venous thromboembolism and ischemic stroke and transient ischemic stroke. And of course, at any part of the body where this occurs, it can also occur in here, and it can occur in the heart. It can occur anywhere in the body where there's a venous thing. So we use heparins, vitamin K antagonists, direct thrombin inhibitors, and factor 10A inhibitors. This mechanism of action of the different ones, if you look at the clotting mechanism, which I'm sure you're absolutely aware of totally, and you probably do this better than I could, is that it goes through a whole pathway from damaged surface right through to the different parts, and then ultimately leading to a clot, cross-lymphatic clot, right to the end. Now, through those pathways, we can inhibit certain parts of these pathways by certain medication. So Warfarin, which is a vitamin K antagonist. We talk about vitamin K antagonists. We only have one in Australia, Warfarin. Coumadin is used in the United States as well, but we've always used Warfarin, and we're using less and less of it now than we used to. Clotting factors depend on vitamin K. Heparin and low molecular weight heparins enhance AT3 inhibition down there somewhere, and rivaroxaban, apixaban, direct FX10A inhibitors. So it's a nice little pathway to follow, and it's something we've over the years grown to understand. Uh-oh. Hello, it doesn't like me. Oh, there we go. Okay, the heparins, very quickly, we've got dalteparin, dataparanoid, enactopyrin, and heparin. And these two are low molecular weight ones. Dapanoid is a low molecular weight heparinoid. Heparin is also known as standard for unfractionated heparin. The mode of actions of these is they inactivate clotting factors, 2A, thrombin, and 10A by binding to antithrombin 3. Low molecular weight heparins and danaparoid have a much greater effect on factor 10A than on thrombin. Again, there's differences between these. And with all the drug groups we have, there's always looking for the differences and getting the advantage that there's more of this and a bit less of that action that's going to occur. That's what you're looking for. Danaparoid is more selective inhibitor of factor 10A than low molecular. So let's look at warfarin. Warfarin was originally used in rat poison. Rats were the only mammals we know that can't vomit. So they couldn't vomit about when they take the warfarin and they'd bleed and they've got a terrible way to die, actually a terrible way to die. But this rat poison has been transferred, of course, you use in humans, not to kill them, but preferably to make them feel better. As you can see, it's a relatively simple chemical structure, which is that's all the chemistry you're going to get on that. So its mode of action, I've already mentioned, inhibits synthesis of vitamin K dependent clotting factors 2, 7, 9, and 10, and the antithrombotic factors protein C and protein S. We're finding out more about even something like we think we know really well the composition of blood. It is amazing. The indication, prevention and treatment of VTE, prevention of thromboembolism in patients with prosthetic heart valves, prevention of stroke in patients with previous myocardial infarction, and increase in embolic risk, and atrial fibrillation and the high risk of stroke or systemic embolism. Now again, you may see patients who come in and are taking warfarin. And one of the views I have, that if a patient is doing well on a medication, is not eliciting or at least notices any side effect, to try to change them to something that might be better is probably not appropriate. If you're going to start someone, that's another story. Of course, you go for the latest one, but if they're going happily, because once you start changing things, you change one thing and many others change as well. So it's still being used, and still a lot of people walking around using warfarin and getting their ionized tests and so on. Warfarin, the precautions, alcoholism, it's contraindicated. Well, that's interesting. You will not be an alcoholic. Compliance is likely to be poor, avoid unless administration is supervised. Protein C or protein S deficiency increases risk of skin necrosis. There's a risk of bleeding, of course. Contraindicated in severe active bleeding of disease states with increased risk of severe bleeding, such as severe uncontrolled hypertension, severe hepatic disease, severe thrombocytopenia. Used with great care in patients with increased risk of bleeding, infrequent falls, severe bleeding. Other drugs that can affect the clotting process, can increase the risk of bleeding. Avoid combinations, monitor closely. In selected patients at high risk of arterial thrombosis, antiplatelet agents may be used with warfarin. I think it's really interesting when you talk about monitoring. Certainly in GP land, and this is something I try to get across, I talk to GPs as well, it really is so important that when you start somebody on something, a medication, or a treatment, it might be non-medical treatment, they need to get feedback. They need to get feedback within a reasonable period. But more often than not, somebody is prescribed, let's say, an antidepressant. Now, antidepressants have got all sorts of issues associated. They take some time to act. But they might say, well, come back in a month. That's fine, because that takes probably at least that long, that sort of thing. But it doesn't take that long to get side effects. They can manifest themselves quite early. And then that particular antidepressant might not be appropriate for that particular patient. But more often than not, something is prescribed and given a month's supply, and nothing else, just take this tablet once a day or whatever it is, what direction they are. No feedback. And I had an experience some years ago which really set me on this path. I went to the dentist. We all went to the dentist, and I don't know what I had done, I can't remember. But anyway, some days later, my wife said, the dentist rang. Well, I paid the bill. Anyway, I rang back and I said, what can I do for you? I was just ringing to see how you're going with your with the procedure. I mean, it's the cost of a phone call. I don't think it was the dentist, it was the assistant. The fact that they made that effort to ring the patient and ask, how are you going? Are you okay with that? That applies to any health professional that brings on some sort of treatment, whether it's physical treatment or medical treatment or biological, whatever. How's it going? Any problems with it? It's such a simple thing. It doesn't cost anything. And nowadays you get phone calls free if you use landline. So it's good marketing. I was really impressed with that. And I think we should all be aware that our patient may not know what to do. They may not recognise the side effect. Warfarin, there's lots. Surgery, risk of bleeding increases as the INR. We'll go to INR in a minute. Low risk of significant bleeding, such as cataract surgery, minor dental and dermatological procedure. It's safe to continue warfarin if the INR is less than 2.5 in people at high risk of fatigue. Elective surgery with moderate or high bleeding risk, if appropriate, stop the warfarin 4 to 5 days before surgery to allow the INR to drop to less than 1.5. Urgent surgery, measure INR to assess the risk of bleeding, seek hematological advice considering using vitamin K and orthothrombin complex factors to reverse anticoagulation. If large doses of vitamin K are used, it can be difficult to re-establish anticoagulation. Warfarin can usually be restarted the night of surgery at the previous maintenance dose. So some of the precautions, older people, increased risk of bleeding, low dosage may be required. In pregnancy, you should avoid use, except perhaps in women with prosthetic heart valves, the risk of tetragenicity or fetal hemorrhage. In pregnant women with prosthetic heart valves, warfarin is more effective than heparins for maternal anticoagulation. For this reason, it can be used particularly during the second trimester until the last few weeks before delivery. The adverse effects, well, the main one is bleeding. And it says greater than 1%, well, you probably need to say it's going to be greater than 10%. But that's a standard, they use greater than 1%. The rare ones, there's nothing in between, a whole bunch of other things, but the big one to watch for is bleeding. I don't think I need to tell you this, you know. The dosage to follow local protocols where available, and hospitals will have different protocol. Treatment depends on indication. The adult oral dose, usually 5 milligram once daily for 2 days, then adjust according to INR. If you're starting someone, and I'd suggest people don't start them on warfarin anymore. There's still some indication. Usual maintenance dose is 1 to 10 milligram once daily, taken at the same time each day. That's pretty important. It's approximately the same time. Target the INR 2 to 3 for all indications except heart valves. For heart valves, seek specialist advice. So I think we talk about INR as if we know what they mean. I'm sure you do. But just in case I've forgotten the exact definition, an INR, or the International Normalized Ratio, is a type of calculation based on prothrombin test results. Prothrombin, PT, is a protein made by the liver. It's one of several substances known as clotting coagulation factors. In healthy people, an INR of 1.1 or below is considered normal. An INR range of 2 to 3 is generally an effective therapeutic range for people taking warfarin for disorders such as atrial fibrillation or blood clot in the leg or lung. The INRs derive prothrombin time, which is calculated as a ratio of the patient's PT, the prothrombin time, to control prothrombin time, standardized with the potency of the thromboplastin reagent developed by the World Health Organization using the following formula. INR equals the patient's prothrombin divided by the control prothrombin. It's a pretty simple thing, but sometimes we get because we say INR, yes, what is it? So I thought I put that in. Some of the practice points that are important with this are the different brands have not been shown to be bioequivalent. They should not be interchanged. There's 2 brands of warfarin, Coumadin, and I can't think of the other one. So if a patient started on one, they should stick to the same brand. But the problem we have now, particularly with the COVID situation, where we're not getting things in where we had, sometimes a particular brand of the product or product disappears altogether or is not available. So it may need a switching to the other brand, might need hospitalization just to monitor the patient carefully while they do the transfer. Warfarin has a narrow therapeutic range. Many drugs interact with warfarin, many drugs. And they think all non-steroidal anti-inflammatory agents will interact with warfarin to a significant degree that increases bleeding dramatically and may decrease the efficacy or increase the risk of bleeding. It is prudent to monitor the INR when changing drug treatment. Consider use of warning bracelets or necklace with warfarin talking about. Advise patients of the intended duration of anticoagulation, the potential risk of stopping treatment without medical advice, stop treatment if skin necrosis occurs. For patients to keep a record of the warfarin dose and give warfarin booklets to fill in, to give the INR results. Review the need for continued warfarin treatment regularly. Certain genetic polymorphisms of CYP2C9 and PKRC1 affect the warfarin dose requirement time to stabilization. However, the clinical value of testing for these remains uncertain. Just talking about drug interactions. Now, drug interactions are really a major component of drug therapy. And drug interactions is actually one of my major areas. And next year, if you're still having, if COVID willing, or other deities that might intervene, monkey plus or whatever, I'd be happy to talk on drug interactions if you like. Full effect of the dose change is not seen for 2 to 3 days. So again, it requires monitoring, real monitoring. When it says caution with, what does that mean? It means you've got to look at your patient and determine what is happening. Determine INR shortly before start. There's a whole range of things anyway. Determine INR more frequently in patients with increased risk hemorrhage and if there are change in the patient's condition such as intercurrent illness such as heart failure, mind thing, hepatic disease, gastric disturbance, infection, thyroid disorder. So quite serious stuff, obviously. Concurrent drugs, big time. Diet, green leafy vegetables consumption and alcohol consumption. If starting warfarin in a heparinized patient, continue heparin for at least 5 days and until the INR is at least 2 for at least 2 consecutive days. So as you see, it's quite specialized use. It was an incredible, difficult drug to use, but now we have better safety. And they come in, there's Coumadin and Maribin, and the various brands, and they come in 1, 2, 3, and 5 milligram, so you can adjust according to their INR. So often a patient will be prescribed 2 different strengths of the same drug. And there's the 2 brands there. Warfarin, no, not Warfarin. This is American. That's funny. That doesn't have the. Forget that slide. Direct thrombin inhibitors. Now we move on directly to thrombin inhibitors. Direct one. So we've got tissue factor, plasma clotting cascade, which drives the prothrombin, and of course ultimately leading to the thrombus or the clot. And there's some of the factors that act in this part. So you've got factor 10A down here, leading to thrombin production. And then there's these that can act, again, block those. You've got platelet agonists, platelet aggregation coming down here. So again, it's looking at the pathway and finding a medication that inhibits that pathway to ultimately prevent this occurring. That's the simplistic approach. So direct thrombin inhibitors include bivalirudin, dabigatran, and ipiridin. And their mode of action is reversibly inhibit both free and fibrin-bound thrombin, preventing conversion of fibrinogen to fibrin, preventing thrombus formation or population. Thrombin-induced platelet aggregation is also inhibited. The risk of bleeding, contraindicated in severe active bleeding or disease states with increased risk of severe bleeding, such as severe uncontrolled hypertension, severe thrombocytopenia, severe bleeding disorders. I think I mentioned those before. So the newer now, I mean, we're talking 10, maybe even 15 years, I'm not sure how long we've had them. They used to be called NOACS, the newer drugs, and I think it's just the anticoagulants now, because if you eliminate some of the others, you can use the others for some reason. And this becomes a bit more complex. It's the same pathway, and that's what we're trying to prevent, the clot, obviously. So there's all the various pathways. So you've got the intrinsic pathway, extrinsic pathway, and what I've got there is putting, whoops, sorry, that's not the wrong way. Where various agents act, and there's this page going through. So as you can see, these, sorry, I wasn't having a senior technical moment, that's it. Various, these are the new ones, act in this particular region here. Heparins and so on act further up on the pathway, so quite effective. And then again, these, of course, the same ones as these, act as at various parts. And you saw when we talk about antifungal agents, the pathways are forming the cholesterol that's going to form and inhibiting that pathway in the fungal membrane. And the higher up the pathway you can block something, the more efficacious it's going to be. So this is just looking at rivaroxaban, apixaban, so in dabigatran, where they act. So this is simplified versions of the same thing, and you can see there they act in those. So anticoagulants for atrial fibrillation. Warfarin, there's many issues, monitoring drug interactions and so on. The newer ones, currently PBS listed with authority, dabigatran, apixaban, and rivaroxaban. They're indicated for the prevention of stroke, thromboembolic, and setting of non-valvular atrial fibrillation. Not indications for indicated, for patients with prosthetic valves or previous valve repair. Warfarin is appropriate for such patients. So there is a use of warfarin. This is looking at the 3 that we have, and you've got that on your handout, so I won't spend too much time. So you've got dabigatran, rivaroxaban, apixaban. Now I believe there are other brands now. They were the original brands. This is from their clinical trials. The mechanism of action in this one, dabigatran is direct thrombin inhibitor. This rivaroxaban is direct factor 10A inhibitor, as is apixaban. So these 2 share the same mode of action, and this is actually probably they're equally efficacious in their appropriate doses. Approved indications, I think we've mentioned those. The dosing in AF, the different types of doses, you can see there's different doses, again, dependent on the molecular structure. Bioavailability, I guess a disadvantage with dabigatran is its very low bioavailability compared to rivaroxaban or 80 to 100% or 50% for apixaban. Bioavailability available to get to the site of action. So you need higher doses of dabigatran. Their half-lives, how long they last. So again, you've got the advantage there. You've got long half-life with dabigatran, which takes 12 to 17 hours, 5 to 9 for rivaroxaban, and 8 to 15. Renal elimination, and this can become quite important. In the case of dabigatran, about 80% or so greater is eliminated. It's not metabolized through the liver to any great extent, but predominantly renally eliminated, which means it's going to have potential interaction with other drugs that are renally eliminated. The rivaroxaban is still fairly high, 66%, but it has a metabolic possibility as well. And in the case of apixaban, it's a relatively low renal elimination. Routine monitoring, and this is the big advantage of this. You don't have to monitor like you have to monitor warfarin. There is no monitoring way. Adverse reactions, where they can all cause major bleeding, and a whole range of things, which are much more benign than warfarin. Just moving on a bit with drug interactions, there are a number of drug interactions. Again, this is really in the case of dabigatran, predominantly through the kidneys. Rivaroxaban and apixaban, a combination of the kidneys and liver. The effect on coagulation tests, the reversal and emergency bleeding. Well, this is an issue. We can reverse if we've got problem. If we've got problem with warfarin, what do we use to reverse the effect? Vitamin K. It's a vitamin K antagonist. In these cases, we really, until recently, had nothing. So they are more benign overall, but they still have issues. So the bleeding risk, hemorrhage rates similar to low or to other anticoagulation, exception high dose dabigatran in older patients. Bleeding risk in warfarin. In patients anticoagulated for AF, risk of major bleeding 2 to 3 per year, similar to warfarin. Risk of intracranial hemorrhage 0.5 to 1% per year, lower than warfarin. So you've got less effect on cerebral hemorrhage than you have with warfarin, but risk of major bleeding is slightly higher. Lower mortality than warfarin associated with bleeding. So that's something. Overall, they tend to be more beneficial. They're not a free lunch. No such thing. There will be in new awards in the future, I suppose. It is high risk for renal dysfunction, particularly with dabigatran, because it's eliminated almost a greater than 80% renally. Severe hepatic impairment can result in bioaccumulation, increased risk of combination with aspirin. And I'm talking low-dose aspirin here. Important to consider time in therapeutic range for warfarin. Even in closely monitored trials, roughly 2/3 of patients have problems. For patients with labile INRs, NOACS may be safer. So if they're taking warfarin and it changes all the time, they have to constantly adjust the dose, they'd be possibly better off transferred to that. If you've got someone that's totally stabilised, as I said at the beginning of this talk, leave them alone. Let them get on with their lives and children's health. Reversal agents, there's a lot of data still lacking. Activated charcoal, if it's recent ingestion, charcoal will prevent absorption. So it's got to be pretty soon after you've taken it. Otherwise, once it's absorbed into the circulation, the activated charcoal doesn't get anywhere. Temporary permanent cessation of drugs, those are short half-lives. So again, half-lives becomes important. This is pharmacokinetic stuff, drug interaction stuff, brilliant stuff. Minor bleeding, well, if you're mad like me, I also like chemical structures. So but I don't use imperial weights. Okay, local measures for minor bleeding, major bleeding, activated charcoal, hemodialysis, the address issue anatomically, such as a GI bleed, antifibrinolytic agents. If at an imminent risk of death, consider prothrombin complex concentrates. So there's, again, you're looking at specialist area hospitalization. Dabigatran reversal and life-threatening bleeding, activated charcoal, if less than 2 hours from ingestion. Now, I would say they have to be a lot less than 2 hours because it's actually quite low. So it's like it hangs around the gut a reasonable time. So less than 2 hours, probably okay. tranexamic acid, antifibrinolytic agents, dialysis, hemofibrillation, filtration, and bypassing fractions from topic. Factor 10A reversal of life-threatening bleeding, activated charcoal if recently ingested less than 2 hours, apixaban less than 6 hours, rivaroxaban less than 8 hours, tranexamic acid, and prothrombin X prothrombotic. So the tranexamic acid is used, again, as an antidote if you like, and this is the pathway that it follows. The NOACS reversals, that's the new ones, resizumab, one of the many MABs. We've got so many MABs that do so many different things. So many different things. These are very, very large molecules. They're called biologicals. So it's a monoclonal antibody that reverses the anticoagulant effect of dabigatran, only dabigatran, not the others, in patients who require emergency surgery or have life-threatening bleeding. It was approved for this purpose by TJ in 2016. Not PBS, but it can be available through SAS. Others, induced alpha, factor 10A, the decoy, they call it, reverses apixaban by short IV bolus infusion, anticoagulant, and there's more coming on board now. And this is basically the dabigatran situation with the adalimumab, and you can see the blood levels are dropping dramatically. And thank you for that little part. So the last one, just straight on you.
Yeah, I think we will.
Oh, we're doing well.
I know.
No.
No.
I learned to talk fast.
Yeah.
Antibiotics. Now a lot of this.
Does andexanet reverse rivaroxaban?
Sorry.
Does andexanet alpha reverse rivaroxaban or just apixaban?
No, sorry, just
Just apixaban.
okay. You'll know this. You'll know all this. This is part of the undergraduate course, and you've had it probably from me before, similar. But we always need to remind ourselves that there have been some changes. Not so much about antibiotics, it's not many of those around. So, surprise, surprise, the references I'm suggesting, and of course you can use whatever references you like, as long as they're up to date, or original research, of course. Okay, don't use that anymore, but I still like it. That was in the original antibiotic guidelines, MINDME, the antibiotic creed. M stands for microbiology guides therapy whenever possible. It's often not possible. Indication should be evidence-based. Yes, please. Yes, please. Narrow spectrum required. Dosage appropriate to a site and type of infection, because again, some drugs can be very effective. Just finishing doing the presentation of the prostatitis and infection of the prostate gland. Now, all the antibiotics that we use for the treatment of urinary tract infection would be very effective for prostatitis. Ladies, you don't have to worry about that, you don't have prostate gland. But most of them do not penetrate to the site of action. So you've got to choose the ones that do penetrate to carry out the antibiotic action. The same organisms that affect the urinary tract infection, but penetrate. So dosage appropriate in site, so that's important. Minimize duration of therapy. And now the therapeutic guidelines are very clearly said that for this particular condition, these are the recommended antibiotics you can use in order of preference, 1 and 1 with 2 might be deemed to be equivalent, based on the efficacy, adverse side effect profile, and of course even cost to some extent. But they will say use so much of this drug, 3 times a day, twice a day, whatever it might be, for 7 days, for 5 days, whatever. And remember, and up to the time I saw you face-to-face last, pharmacists will still say to be taken until finished. That has now gone. I have been advocating to get rid of that label. It is so wrong.
Why is that? Because we're always told to take it, otherwise it's not effective.
Yeah, no, well, yes. Well,
That's
that was a
what-
rationale, and
yeah.
it was valid up to the point.
Right.
What if all you need is a 3-day treatment? So, for instance, if you've got a urinary tract infection and you're going to be treated with a 3-day course of trimethoprim, which is standard if you're not pregnant. Okay, if you're pregnant, it's different drug. Okay, but they comes in packets of 7. And do you put on that label to be taken to the finish? No. It's a 3-day treatment. You don't want extra antibiotic in your body. It causes all problems. So it's interesting because I've fought for the last 20 years to get rid of that level. I said it is inappropriate. Finally one. It is inappropriate, and it is right across Australia and New Zealand that we had to be taken for the appropriate period of time as designated by your prescriber, which should correspond to what the therapeutic guidelines are. Now that was a big political issue. You have no idea. Such a simple change, yet because people were used to doing it. I did it myself when I was working to be taken into a clinic. And the argument was that you need to keep the blood levels up to make sure that you're really getting that organism. And that was a valid argument. But we now know from lots and lots of trials and practice that you don't need to go beyond 3 days, say for a urinary tract infection or trimethoprim. And so you've got these extra 2 tablets. So of course you've got them there, you take them. You don't need them. And there's no such thing as a friendly chemical. They all have potential side effects. Okay, move on. This is the third Australian report on antimicrobial use and resistance in human health. So relatively recent, it's the most recent one, 2019. There's 26.5 million antimicrobial prescriptions dispensed in Australia annually. At that time, it's probably dropped off a little bit. In a hospital, 23.5% of antimicrobial prescriptions in hospitals were inappropriate. Many, many studies and surveys, and I've been involved in some of them, that doctors will prescribe inappropriately. They'll prescribe an antibiotic when not needed, or they'll prescribe the wrong antibiotic for the wrong period of time. They're only human. 11% decrease in 4 years in prescriptions for surgical prophylaxis beyond 24 hours. Now the recommendation is not to go beyond 24 hours, but some people will still go beyond that. The community, 50% of antibiotic prescriptions are ordered with repeats. That's the other thing. Doctors can't order repeats for antibiotics anymore. If you think you're still sick, you come back and see me. We may need to change the antibiotic. It may be the wrong thing. So they can't issue repeats. I think that's happened in the last 2 years. So COVID has brought on some pretty good things. It was happening before that. Staphylococcus aureus is higher in remote and very remote regions. Community-associated MRSA, medicinal resistant Staph aureus, is particularly common in aged care and remote regions. In aged care, 1 in 10 aged care home residents were prescribed at least one antimicrobial. May be appropriate, may not be appropriate. More than half of antimicrobial prescriptions were for aged care residents who had no signs or symptoms, just in case. That's bad medicine. I am not trying to attack the medical profession. I've got the greatest admiration. I'm a frustrated doctor at heart. Classes of antibiotics, you're aware of these, the penicillins, the cephalosporins, the carbapenems, the aminoglycosides, the fluoroquinolones, tetracyclines, the lincosamines 2, glycopeptides, macrolides, nitramidazole. It looks like a lot, but it's not. Others, folic acid antagonists such as trimethoprim, nitrofurantoin, nisolid, and rifamycin, which we'll get to. The antibacterial for podiatrists, of course, as you know, oral penicillins, amoxicillin plus clavulanic acid, dicloxacillin, flucloxacillin, phenoxyethyl penicillin for pediatric surgeons only. You're entitled to prescribe those, but for one course. And the same as GPs now, for one course only. If they want more, they have to come back and a new diagnostic test carried out. Parenteral penicillins, amoxicillin, dicloxacillin, fluclox, pediatric surgeons only. Diclox and fluclox are pretty much the same. The only thing here, just slightly higher chance of liver problems associated with fluclox compared to dicloxacillin. But they have exactly the same physical chemical nature, they have the same indication, the same dosage, everything else. So I would tend to go for dicloxacillin, just to be able to say so. Fluoroquinolones, ciprofloxacin, you're allowed podiatric surgeons only, Cipro. And most commonly prescribed antibiotics in Australia are penicillins, cephalosporins, macrolides, tetracycline, trimethoprim, metronidazole, and fluoroquinolones. Resistance. And that came out in Nature 2011, and it still stands. We will not find an antibiotic which will not also have a resistant gene out there. So if we keep bringing on new antibiotics, there will be some resistance will occur It might start very slowly and develop. It originally started with the penicillins. So what is it? What's antibiotic resistance? Why is it such a problem? I'm sure you know antibiotic resistance happens when bacteria change to protect themselves from an antibiotic. And just think what's happening with COVID. The various strains that we're getting, the viruses do the same sort of thing. And they mutate at a much faster rate than bacteria do. They mutate. Now, I had an incredible experience a few months ago. I went into a pharmacy with my wife, and she was looking at cosmetics, and the pharmacist saw me from behind the dispenser and recognized me. And she said, Professor Roller, 30 years ago you told us as students about the pandemics, about not if, but when. That's true. Microbiologists have been saying forever and ever, we're now in a pandemic, and there's going to be new ones. And there's variants of the old one, forever and ever. And eventually they'll outsmart us. Okay, with bacteria, then they are no longer sensitive to that antibiotic, and this happened. The antibiotic previously would have killed or inhibited the bacteria or stopped them from multiplying, no longer work. So what happens, you keep taking that antibiotic, and that's one of the major reasons to take it for the period that is required for that particular condition. Because as you take your antibiotic longer and longer, and it might only be a matter of days, the risk of resistance increases quite dramatically. So that's the answer. So I hope everyone's clear about that, because that really is important. Not to be taken until finished. Sometimes that is the case because the numbers coincide, but generally speaking, for 7 days, 3 days, whatever it is. So the superbugs, of course, are the multi-drug resistant bacteria that are resistant to several different antibiotics. Methicillin-resistant Staph aureus, MRSA, was the first one identified a long time ago. Bacteria commonly found in hospitals, the bacteria that cause tuberculosis, Mycobacterium tuberculosis, and the bacteria that cause serious lung disease. Pseudomonas aeruginosa, a very nasty drug, very hard to control. The fluoroquinones, ciprofloxacin is an oral drug, an oral drug of choice, but generally if it's really bad, you have to go to intravenous cephalosporins. Strains of E. coli, the bacteria that causes many urinary tract infections, have also developed resistance to a number of antibiotics. And this is just some pretty pictures of the different organs. They look gorgeous, don't they? They look so innocent. And generally speaking, they are. They sit there in our body and they're quite happy and we're quite happy. So what does the World Health Organization have to say? Yes, they took a long time to tell us we had a pandemic, but they did get there eventually. But this is to do with antimicrobial resistance, threatens effective prevention of treatment of an ever-increasing range of infections caused by bacteria, parasites, viruses, and fungi. Microbes as a whole, microbial world. An increasing number of governments around the world are devoting efforts to a problem so serious it threatens the achievements of modern medicine. A post-antibiotic era, we could have a play called Post-Antibiotic Era, and it'd be like, a new Trump era, probably could. Sorry, can't help myself. Anyway, post-antibiotic era in which common infections and minor injuries can kill. Because many of the infections we get and treat with antibiotics in the past themselves were lethal, but now we've got them under control. If the antibiotics lose their efficacy, we're back to where we started. Multi-drug resistance, the condition enabling disease causing microorganisms, bacteria, viruses, fungi, or parasites to resist distinct antimicrobials, first and foremost antibiotics, but also antifungal drugs, antiviral medication, antiparasitic drugs, chemicals of a wide variety of structure and function targeted at eradicating organisms. Some examples of antibiotic resistance, there's a whole list of them that's probably grown. Staphylococcus aureus resistant to penicillin, methicillin resistant to Staphylococcus aureus, ampicillin resistant, so ampicillin resistant E. coli, Haemophilus influenza, Neisseria gonorrhea, gentamicin resistant enterosis fecalis, and so on. And there's more. And of course, bacteria, we learn, will multiply by division, and they are asexual. False news. They do that, but they also multiply or divide sexually. And those two are having a go at it, and they're transferring, they are transferring DNA material from each other, and one of them has got a multi-drug antibiotic resistant gene in there, and it gets across to the other one that's not, so they can transfer of material. Yeah, they're having a good time. That should be X-rated. Okay. So bacteria then, this is just a summary of that. Indiscriminate use of antibiotics. Pseudobacteria. Now, of course, with antibiotics, we have another big issue because antibiotics are used in the food industry, particularly with cattle, so on. We're getting big doses of antibiotic chickens and a whole range of animals that we eat. There's a good case of being a vegetarian. I'm glad I'm going to die before I have to do it. There we go. And certainly that can get into the situation. The resistant strains spread rapidly. This is quite old, but it's the trend is there. It doesn't matter. It just shows the various methicillin resistant Staph aureus, vancomycin resistant cocci, fluoroquinolone resistant Pseudomonas aeruginosa. Now, Pseudomonas is nasty, and ciprofloxacin is a good drug, but my wife's respiratory physician has prescribed it for her a number of times, but he's very reluctant to do it. For good reason, for absolutely good reason. He's terrified that it'll become resistant, that the Pseudomonas will become resistant, and then be untreatable. And there's only one outcome of that. Well, we know all that. I think we've dealt with that. Okay, the antimicrobial resistance increases morbidity, mortality, and cost. Antimicrobial stewardship now has been implemented in most of our hospitals and in medical practices and in pharmacies. Medical, I include other allied professions are involved in medical stuff. Antimicrobial stewardship in the patient setting, appropriate antibiotic. So the choice has got to be the right choice. How do you determine that? I've got an infection, I think we've worked out what it is, we did a test and we found that it's such and such. Where do you go? You go to the antibiotic guidelines. That's what they're designed for. And he said the person suffering from this particular condition with this organism, here are the recommendations of which medications to use, how much, how often per day, and for how long. That's what it boils down to. That's what all the therapeutic guidelines are about, all of the various therapeutic guidelines. Appropriate antibiotic correct dose, optimal duration. The stewardship, simplistically, is antimicrobial stewardship describes a systematic approach to optimizing the use of antibiotics. We're not saying don't use antibiotics, of course not, and they save lives, but to do it properly. The aim of antimicrobial stewardship program is to improve patient outcomes, reduce adverse effects, including antimicrobial resistance, toxicity, unnecessary cost, by optimizing antimicrobial use. So this is motherhood statements, but so important. The hospital staff did this, so you know it's a hospital staff. Adverse reaction to antimicrobial. Now, it's interesting, when in the early years where I was at the pharmacy college, we had a separate department of pharmacology, and we had a head of department there, and he came from the UK. In those days, if you could only have professors from the UK, you couldn't have professors in Australia. Anyway, he came from a school of thought that said, well, we don't, in the textbooks, you'll find many pharmacology textbooks will not have anything on antibiotics because they're not drugs. They don't affect us, they only affect organisms. Now that is of course a total nonsense. Now you'll find most pharmacology books, the two that I've got there, there's big sections on antimicrobials, but a very, very narrow-minded approach. So therefore we don't need to know about it, was the attitude. In the pharmacology, we taught it. I actually taught it in other areas, but it was incredible. And you still have, even in the academic world, you get people stuck on things that they thought was right, and for whatever reason, and so on. So because the drugs don't affect us, so the implication is it doesn't have side effects. They don't have side effects, and this is to basically I wrote that article to the Australian Society of Antimicrobials quite a long time ago, 2005, and I gave a copy to my colleagues, and I never heard a comment about it. My friend Hippocrates, who did pharmacy with me back in 2005, said, first of all, do no harm. That is for every single health profession, isn't it? First of all, do no harm. Adverse drug, the world definition of an adverse drug reaction, a noxious, unintended, or undesigned reaction occurring in doses normally for the prevention, diagnosis, and treatment of disease. That's quite old, but it still stands. Hazards of antimicrobial therapy. Allergic reactions. There's type 1 reactions, such as penicillins, cephalosporins, sulfonamides, and quite a few others. So we train our pharmacists, supposedly. They supposed to, when a prescription comes in for an antibiotic, have you had this before? Yes, I have. How did you go? Well, it was fine. Oh no, as a matter of fact, I came out, I'm allergic to it. Tell me what you mean by allergic. Well, I vomited it up. Well, that's not an allergic reaction. I came out in a big rash. That's an allergic reaction. Or I've started to swell up. And I was taken to the hospital and I almost died. That's a real allergic reaction. I mean, there's levels of allergenicity. So we need to ask the question. And it's not just saying, are you allergic to this? Or have you had it before? Oh, yes, that's okay. We need to ask about what experience they had. It was fine, that's fine. Doesn't mean you might, you could still become allergic later. But generally speaking, I mean, there's only so far you can go. So, superimposed infections with broad spectrum antibacterials that act on a whole range of different microorganisms. Isolate out, for instance, Clostridium difficile. So broad spectrum, and we tend to, where possible, use narrow spectrum that they'll act, the antibiotic will act on a certain range of gram-positive or gram-negative bacteria, whatever the case is, rather than the whole range of bacteria. Because that encourages isolation out of this nasty creature, Clostridium difficile. Monolaces or fungal infection with broad spectrum antibacterial. Again, we've got fungi and bacteria living very happily with us, and we've got a bacterial infection, we're taking an antibiotic, and suddenly the whole flora within the gastrointestinal tract has changed. And the fungal spores sitting there very happily doing nothing, suddenly say, oh, the environment's changed. I think I'll start reproducing. That's what happens if you want to anthropomorphize that way. Gastrointestinal tract upset, including mild diarrhea, which is very common with antibiotics, because you're upsetting the whole flora and fauna within the gastrointestinal tract. So you talk about mild diarrhea. If it gets beyond mild, then you've got a problem. Blood disgraces such as chloramphenicol, which we don't use anymore, and sulfonamides, which we hardly use these days. Neurotoxic effects such as aminoglycosides and fluoroquinolones, they get into the central nervous system. Aminoglycosides can cause deafness in some people, can cause imbalance, a whole range of nasty things, and the fluoroquinolones can cause a whole range of problems in there. This is a typical penicillin rash. It's not a particularly good picture, it's an old one. I should get a new one in there. But you can see very, very fine rash all over the body that reacts to penicillin. This is a different sort of rash, isn't it? This is, I call it squash flowers, but it's that can be quite serious, that can be life-threatening. What's happening in the skin can be replicated throughout the whole body. And again, this is the same person. Oops. Nephrotoxic reactions, working in kidneys, aminoglycoside, cephalosporin, acetate. These drugs are eliminated almost entirely by the kidneys. Therefore, if they're competing with other drugs eliminated that way, they can increase the plasma levels of one or both of the components, and therefore create a problem. So again, you need to be aware of that. Pseudomembranous colitis are more common with nicotinamides, clindamycin, lincomycin, and cephalosporins. This is Clostridium difficile. Interactions with other drugs, fluoroquinolones and macrolides, roxythromycin, tetracycline, gluconazole, rifampicin, all have a whole range of drug-drug interactions. They are contraindicated in pregnancy, categories C, D, and X, some, mostly not. This is a very nasty situation with cotrimoxazole, the same person again, and this is on the skin, same person. This is, the sulfamethoxazole and trimethoprim, serious reactions that can occur with them. Sulfatrimoxazole plus trimethoprim, Bactrim, Cetrim, those brands, they're still around and they are used for a number of purposes quite legitimately. Generally speaking, should be avoided in people about over 45. If you look at the age there and side effects, around 40, 45, they really start to increase the side effects. So again, it might be a life-threatening situation, you've got nothing else we can use. But generally speaking, there are alternatives. This is tetracycline, teeth. Interesting, I've probably told you this in the past. Oh, okay. Yeah, well, I'll just get back to the teeth for a second. Tetracycline teeth. In 1968 it was, a big study came out of the United Kingdom about the effects of tetracycline and combining with calcium of the teeth, but which you can see, but also of the bones, which you can't see. So it combines with the calcium, and they can cause the teeth to break and bones to become fragile. And so it was therefore recommended that tetracyclines should not be given to pregnant women or should not be given to children under the age of 8. And later, the dental guidelines said to suggest preferably under the age of 12, should not be given under the age of 12. The latest antibiotic guidelines are still sitting on the fence and saying 8, and said that other practitioners say 12, and they really should be saying 12. But anyway, that's what it goes. But the interesting thing is that article came out in 1968, big study, and we had them flown out, all the journalists from the UK and other country, and we read about this. Now, in 1979, that's 11 years later, on the pharmaceutical benefit scheme, it was the last time they had 9 different brands of a pediatric tetracycline preparation. It took 11 years for the message to get through, not to prescribe those for children under the age. It said 8 of those days, but it should be 12. So it's quite. I think we're a lot faster these days with the internet. Thank goodness. The antibiotic-induced pseudomembranous colitis due to antibiotics. It's interesting. So this is Swedish stuff. It's quite old, but it gives you a pretty good idea that the lincosamides, that's clindamycin and lincomycin, which you have access to, and they can cause that after 1 or 2 doses or after a long period of time. It's no way of knowing. And that's quite serious. The pseudomembranous colitis is usually what happens is a person suffers from explosive, bloody, mucousy diarrhea, and they become dehydrated extremely quickly and can die from it. It's hospital situation. The lincosamides are the worst. The cephalosporins the next in line. So if you take phenoxymethylpenicillin and call it 1, these are all relative to phenoxymethylpenicillin. So you can feel pretty safe with phenoxymethylpenicillin from that point of view. The penicillinase resistance ones are about 10 times. Broad spectrum penicillin, they're much the same. Trimethoprim sulfamethoxazole, it's got lots of problems, but that's not one of them. Tetracyclines, definitely not. These others, and fluoroquinolines, the figure is probably getting around 60% as well. The fluoroquinolines have got lots of issues. Again, life-saving drugs in the right situations. And this is just Clostridium difficile in the gut. This is on autopsy, so the patient's not feeling anything anymore. And pseudomembranous colitis if you look down into the gut. Likely side effects of a group of antibiotics. I like to put that, it's a very rough guide, but it's quite useful. You've got the penicillins, the cephalosporins, tetracyclines, cotrimoxazole, which is trimethoprim sulfamethoxazole, which you don't have access to. The macrolides, which you have, fluoroquinolines, you've got access to. And basically, they can all cause skin reactions. This is very rough. Diarrhea, by definition, mild diarrhea. So you've got to differentiate between what is mild, self-limiting diarrhea to explosive, nasty diarrhea. Nausea, they can all do that. Again, gut effect, as you can imagine. Vomiting, similarly, except with the penicillins, doesn't seem to be a problem. Itching, joint and pains, penicillins and cephalosporins. Headaches, fluoroquinolones, they get into the central nervous system, and they're not a good idea for older people because they can make them feel woozy, they can fall, and again, if you go to nursing homes, that's an issue, so you've got to be careful about that. What's their walking like? And they can feel quite confused with them getting into the central nervous system. For the same reason, headaches, cephalosporins, because they get into the central nervous system and can cause headaches in some people. Fever, interestingly enough, you'd expect to reduce fever with antibiotic, but it can increase with penicillins and cephalosporins. Dizziness, again, the fluoroquinolones for the same reasons as before. Tendinitis, now that's an interesting one, and that really applies to you. So let's just move on to jaundice for a second, get back to tendinitis. So jaundice can occur with some penicillins and can occur with erythromycin of the macrolide. Now let's get back to tendinitis. I've got something there. No, okay. No. So tendinitis can be caused by all fluoroquinolones. There are 4 of them on the market available in Australia. It's a group thing. We don't understand the mechanism of action, but it can manifest itself as tendinitis. I'll come and see a podiatrist. And again, history taking, and you find that person last week or the week before, whatever, was prescribed a fibroquinone. So again, it's not what you're prescribing, it's what somebody else has prescribed that is causing the issue that makes them come to you. And so again, history taking is so important. In our pharmacy registry, and our pharmacy is the one of the 14 health professions in Australia, pharmacy and now psychology, and we've had it forever, psychology only introduced it last year, that there is a registration exam. So you finish your undergraduate degree. Unlike medicine, you become a doctor, and podiatry, you become a podiatrist, and so on. In pharmacy, you do a 4-year undergrad degree, then you do a 1-year internship program, and then you come back, and the registration authority, the Pharmacy Board of Australia, Podiatry Board of Australia, etc., but in our case, we're the only ones, plus psychology now, will do a practice-based series of oral examinations. And it's based purely on the safety of the patient. And that is really, I believe all the health professionals should do it, but of course, that's not going to happen. But it is really, in fact, we've got exams coming up very shortly. That's really quite, I'm still an examiner for the pharmacy board. And it's really interesting to see, you see these fresh, bright people coming in, and then you walk outside and you see chemists, bloody warehouse. It makes you want to vomit, doesn't it? The chemist warehouse hates me. What is the appropriate duration of treatment? We'll get back to your question. The shortest possible duration of therapy should be used, consistent with the condition being treated and the patient's clinical response. That was the Australian Prescriber 2019 and the Therapeutic Guidelines Antibiotic version 6. And now the Australian Pharmaceutical Formulary, which has all these extra warning labels, has removed that to be taken until finished, to be taken for the appropriate time required. This is the big check. So let's look at a couple of scripts. So this is somebody who's prescribed just general stuff, not your specialist area. So here's James Patrick, was prescribed today. Well, that's interesting, fresh script. For Augmentin Duo 4, doctors still tend to prescribe, even though more and more now they're prescribing generically, which is good. Augmentin is amoxicillin. Good Lord. It's amoxicillin plus clavulanic acid, right? The clavulanic acid increases the efficacy of the amoxicillin. And in the early days of being introduced, about 30 years ago now, people would come in, there was a sudden insert of Augmentin prescription. It was the only brand it does, any brand. So the brand doesn't matter. And people would say, and would ask the question, have you had penicillins before? Oh, I'm allergic to penicillins. The doctor said this is a new super drug. This is a super penicillin. Yes. It's again, prescribing by trade brand, not a good idea. And you might remember, for you, those of you who had me for your anyone been to my undergraduate lectures? No? Oh, a few years ago. Oh, that's nice. Yeah, obviously, you have to ask questions. Don't assume. Preferably don't use trade names. You don't need to. There are, not so much in the areas that you've been practicing in, but for some, I mean, Warfarin would be one. You'd use a trade name. But generally speaking, not. Oh, so what's the problem? This person is actually allergic to penicillin on questioning. Okay, this one. And Anthony Albanese, there we go. The new kid on the block. Ciproxin, tabs, 500, ciprofloxacin. The trade name is ciprofloxacin, 21, take one 3 times a day. Phenytoin capsules, this was, well, normally that mightn't be on the same script, but it could be on the record. What's phenytoin used for? Epilepsy. Now, most drugs have got multiple indications. Phenytoin is used for epilepsy and epilepsy only. It's probably the oldest anti-epileptic drug we have, and it's not been approved for treatment of anything else except epilepsy. Now, is that an issue? Now, I'll put it on prescriptions just to, to make it easier. You can see that yes, there is an issue. If the patient is suffering from epilepsy, ciprofloxacin will interact with phenytoin and reduce the plasma levels. Oh, sorry, no, that's not right. Ciprofloxacin will get in the central nervous system and can promote epileptic fits. So it's contraindicated in patients with epilepsy. Okay, so again, this wasn't thinking straight, not going into the full thing. Oh, the patients come in for something. You see this more in medical practices. They come into a very specific thing. And so the doctor gets very concerned and wants to do all the right things. Of course, everybody does. But they don't take into account what else the person's suffering from. It should be so obvious. Just had a terrible situation with a neurologist recently who made proclamations about my wife. He had taken look at any of the evidence just based on what it said. Okay, for Penelope, well, now there's a woman I like. Fluoridatin, nitrofurantoin. I love putting politicians in. It's 100 milligrams, 100 milligrams, 31 4 times a day. Again, you'll notice there's no times that it's taken for than it should be. And urine sachets, one packet, one exactly with water and 4 times a day. This is prescribed by Sigmund Freud, my old friend. Fluoridatin, nitrofurantoin, urinary tract infections. Urel, it is a salt combination which alkalinizes the urine and reduces the effect of when you have a urinary tract infection. Ladies here, probably you've had one sometime in your lives or more. When you pass urine, it really stings, right? And this quantum of stinging, well, you're nodding, so I thought you were volunteering. So that's fine. It doesn't do anything to the microorganisms. It doesn't do anything to the infection. But what it does do, because the urine, healthy urine, is normally around pH 5.5. That is acidic. What urel does, it pushes the pH up to make it alkaline to about pH 9. You know the scale, 1 to 14. Okay? Now what that does is deactivates the nitrofurantoin. Totally. It's totally useless. So again, a little bit of practical knowledge is so important. Fred and I, 3 years old, there we go. He's been prescribed Keflex suspension, which is Keflexin. And again, this was an issue where he had turned out that, again, this happened to me when I was relieving in a pharmacy. Lovely woman comes in and she had a 3-year-old and he had an infection. And so I asked the usual question, as he had penicillins before. He said, oh, he's allergic to penicillin. That's why the doctor prescribed this. And I said, okay. People say they're allergic, and that could mean a whole range of different things. Well, can you tell me what happened? Oh, it was catastrophic. He ended up in hospital, had intravenous drips. That's allergic. So I rang the doctor and eventually got back to him. And he said, look, that's why I prescribed Keflex, Keflexin, if you're allergic. But the severity of the allergenicity is that it is, all cephalosporins are contraindicated in people who are type 1 hypersensitive like that child was. And that could have killed him. And I also was an expert witness in somebody died, what do you call them, a coroner's court. And it was about a similar sort of thing, where the doctor prescribed Keflexin for someone to be allergic to penicillin. That was different. The patient took 1 dose and was dead 20 minutes later. And we knew that was corroborated by a neighbour who was going to have a cup of tea. She found it dead on the floor.
Louis, I've had that conversation with several anaesthetists lately, and they tend to refute that now.
Well, you can use cephalosporins if you're allergic to penicillin, as long as it's mild to moderate allergenicity. If it's severe, like what I've just described.
No, they're saying that the linkage is definitely there.
Well,
no, I'll
have to check on that.
I've had 3 separate anaesthetists.
Yeah, I'd still be very aware.
What they say is there's a correlation, not a direct pharmacological.
It's not a pharmacological.
We did have a patient nearly die last year.
Yeah.
And there was big debate.
Well, the thing is, there are people who have died.
Yeah.
Using it. And if you look at the antibiotic guidelines,
that thing is a 10% cross-sensitivity.
yeah, about 10%. About 10%. Even though that's changed, it is less. It's probably less than 10% now, and I think that's a very quickly. Some of the I've got 15 minutes, all right?
Yeah, yes, thank you, that'd be good.
Yep, okay. Well, I'll do very quick because you'll know most of this. The penicillins. Now, here's the guy who got the Nobel Prize in sugar. That's Fleming, because it was Florian Chain that really knew what to do with it. Fleming discovered it, and he thought it was very interesting, and that was about it. He didn't realise what it could be done with it. And then Florian Chain, from Australia, Melbourne Uni, actually, during the war, worked out what it was. So there's penicillin. It's basically, all the penicillins are based on that structure, and lots of side chains and so on. Antimicrobial hypersensitivity, we talked about, broad term for unpredictable adverse drug reactions which can be caused by immune-mediated or other mechanism. And allergy refers to immune-mediated mechanism. Immune-mediated hypersensitivity and allergy are used interchangeably, probably not totally correctly. It's common for patients to report a history of allergy to an antimicrobial, usually penicillin, and this can present a clinical dilemma. There may in fact not be. If the antimicrobial is administered to an allergic patient, a severe reaction can occur. Doesn't mean it will, but can. However, it's known that many patients who report an allergy tolerate the drug if it is administered again. So there's a whole lot of provisos taken into account. It's probably not as bad as it can, but if you or a loved one dies, you'd be a bit cautious. There's a whole range of 90% of reported penicillin allergies can be excluded by antibiotic allergy testing. People want to be allergic to things. You say, I'm allergic to this. Careful assessment and confirmation of antimicrobial ensures the patient receives the effect and so on. Accurate, detailed information. If a reported allergy is subsequently excluded, update the medical record to avoid relabeling, include information about how the allergy has been excluded. So that tries to take into account your concerns. So the non-IgE mediated penicillin rash, urticaria, which I showed before as well, different slide. I did the same slide as before. That's urticaria, of course, squash flower. This, of course, is notice the eyes and not so much on the lips here. Principles of appropriate prescribing for surgical antibiotic prophylaxis. The following principles guide antibiotic prophylaxis. That's for you to prevent post-operative infection. Do not use antibiotic prophylaxis unless there is a clear indication for its use. Yep. When there's a significant infection. Antibiotic selection may need to be modified according to patient risk factor, such as pre-existing infection, recent antimicrobial use, known colonization with multi-drug resistant organisms, prolonged hospitalization, or the presence of prosthesis. Antibiotic pharmacokinetics are altered in obese patients, so dose adjustment may be necessary. So another reason to watch your diet. The optimal time for preoperative IV antibiotic administration is within 60 minutes before surgical incisions, and you've done some of this, I suppose. Suggest administration 15 to 30 minutes before surgical incision may be optimal. A single dose of antibiotic usually sufficient for the significant majority of procedures. That's your experiences. A repeated intraoperative dose is required if the procedure is prolonged and the drug has a short half-life. So again, understanding the kinetics of your drugs is really quite important. And because you only have access to a limited number of drugs, you really should know them. Prophylaxis should not extend beyond 24 hours, regardless of the surgical procedure. Neither IV nor oral antibiotic prophylaxis offers a benefit beyond this period. Okay, some penicillins, phenoxymethyl, that was the first orally active penicillin in the early 60s. Amoxicillin was the first broader spectrum penicillin by simple minor changes in chemical side chains. Dicloxacillin and flucloxacillin are identical, except flucloxacillin has got a fluoro group up there, and this has got two fluoro groups. They are basically identical in efficacy and in dosage and frequency. And then we've got amoxicillin plus clavulanic acid, which of course the clavulanic acid has little antibiotic activity, but what it does is inhibits the enzyme that breaks down the penicillin structure, and therefore allows the amoxicillin in this case. It can be with other penicillins as well, but mostly with amoxicillin. So phenoxy, I don't think I need to go through this one, which is good. I'm very conscious of your time. Just quickly, you are only podiatric surgeons are allowed to prescribe that. No, I'm not saying GPs can't, but normal podiatrists can't prescribe phenoxymethyl penicillin. It's narrow spectrum, which is a positive thing, effective against gram-positive organisms. Its indication, staph pioneers with tonsillitis, which you probably won't treat, pharyngitis or skin infections, prevention of rheumatic fever, moderate to severe gingivitis with metronidazole. So I guess you're looking at skin infections. Practice points: phenoxymethyl is less active than benzyle, which is the parenteral form. Generally reserved for situations where high tissue concentration is not required. So again, it depends what you're going. There's dose forms of capsules, tablets, 250 and 500 milligrams. Pediatric preparations. There's a whole bunch of brands. That probably doesn't cover half of them now. Now, amoxicillin, beta-lactamase labile. Amoxicillin, sorry, yes, I did say it is beta-lactamase labile, which means that the structure can be broken apart by that enzyme, the beta-lactamases, plural, and inactivate them. Same with phenoxymethyl and pretty much the same sort of things before, but the advantage of it is that it's got some gram-negative effect, and only needs to be taken 3 times a day, not 4 times a day. The other one does, and should be taken on an empty stomach. Amoxicillin doesn't matter, so it's a big advantage that way. So again, sometimes efficacy might need to be traded off for ease of use. Sometimes. In this case, the efficacy is much the same. Beta-lactamase resistant penicillins came on the market quite a few years ago, and you can see the side chains that are huge compared to the other ones. So basically, there's your penicillin moiety there, and there's the side chains. The other side chains and the others tended to be very small. And what that does is actually protects the molecule from the lactamases, the enzymes. So diclox, fluclox, and of course the treatment is one. It is a bit like the corticosteroids I had before. The indication: serious staphylococcal infection, including pneumonia, osteomyelitis, skin and soft tissue, wounds, infected blood. So of course that would certainly be within your realm. Renal problems: reduce the dose of creatinine clearance less than 10 mil. So your kidney's pretty shot when you get to that stage. Generally, in other words, generally speaking, it's okay. Hepatic contraindicated with a history of cholestatic hepatitis with diclox or fluclox. Risk increases in people over 55 and when courses are greater than 2 weeks, which you try to avoid anyway. Not always possible. Common adverse effects: 1 to 10%, local pain, thrombophlebitis by injection, transient increase in liver enzyme bilirubin. What does it mean? The doses, they're the same for both, 250 to 500 milligrams, 4 times a day, at least half an hour before. It's a bit like phenoxymethyl penicillin from the point of view of dosages. Must be on empty stomach and the appropriate children's dose. So it is 4 times a day, which is a nuisance, and it's hard to adhere to. But that's the way it works best. Even though they try, in some of the conditions, they will say double the dose twice a day, but not all. Amoxicillin plus clavulanic acid, so that is a broader spectrum because of the addition of the clavulanic acid I've already mentioned, but it's not effective against methicillin-resistant Staph aureus. And skin and soft tissue, so that's certainly a common one. This is probably, of the penicillins, probably amoxicillin by itself, and then probably this number 2. Common adverse effects: transient increase of liver enzyme bilirubin, not sure what it means, but you can have liver problems in some people. And this is a twice daily dose, a 12-hour interval, which is terrific, and that's a big issue. The products, a whole bunch of products. I don't have all the brands there, many brands. Cephalosporins, very similar to penicillin. So on the left you have the penicillin basic structure, and on the right you have the cephalosporin structure. The major difference being this here. This is a 5-membered ring from the sulfur down to the carboxylic acid. Here this is a 6-membered ring, but the configuration of the sulfur to this carboxylic acid is the same. So it has the same mode of action, same activity, but of course a whole range of different potencies. Cefalexin, this is the one that's most commonly prescribed after cephalosporin. It's orally active, which is a big plus. Moderate spectrum, it is gastric juice stable, which is great. A whole range of indication, and it's got a whole range of adverse effects. Severe renal impairment, that's severe, less than 10 mils per minute. The macrolides, erythromycin was the first from natural sources, and you've got yes, erythromycin, clarithromycin, azithromycin, and roxithromycin. Erythromycin is hardly used these days. It's got lots of drug interactions, and it's got quite a lot of side effects. So roxithromycin is the most common one used, the oral form, and I think you've got access to that. Bacteriostatic, inhibits bacterial protein synthesis by binding to the 50th subunit. The penicillin act on the cell wall of the bacteria. It actually breaks the cell wall apart. This acts actually within the ribosome of the organ, quite different mode of action. And it's used for a whole range of different things. It can cause potential problems, severe hepatic impairment, reduced dose. Leukosamides, lecomycin, clindamycin. Leucosamide is often used where you've got a person who cannot take penicillins or cephalosporins with severe hypersensitivity, and they are used instead. Generally speaking, the clindamycin is the better of the two. Again, it's a bacteriostatic inhibitor to the 50S ribosomal unit. It's a different action. Indication, alternative in patients with immediate hypersensitivity. So you've got, when you talk about hypersensitivity, you've got immediate. By immediate, it can happen within a few minutes or a few hours. By delayed, you're talking days or perhaps a couple of weeks later. And it's an immediate one that is life-threatening. That's where that's used. So you'll find, generally speaking, if a person needs to be treated with a cephalosporin and they had shown a delayed hypersensitivity to penicillin, you could use a cephalosporin. And if it was an immediate one, that perhaps helps, which we were discussing before, you would use a clindamycin. And that's, again, some of the reactions to it. The fluoroquinolones, the only one is ciprofloxacin that you've got available to you. Levofloxacin has just come back on the market. Well, it's never been on the market systemically. Just this last month has been available, I think, through SAS, and they may put it for general use later. This is a synthetic compound, and it's a totally different mode of action again. It reacts on DNA, blocking DNA gyrase and stopping it. Now, those drugs have got a whole range, particularly Cipro, which is the most common one used, has a lot of particular problems. All of them have got problems with tendon damage, can cause, doesn't mean you get it. I mean, you could take multiple courses of it, you'll get resistance long before you get tendon damage, but it can occur. So it's, I forget what the figure is, but it's people who are taking corticosteroids and more at risk tendon damage, so you need to watch out for that if you're looking at that. It can increase QT interval in the heart. It has many, many drug interactions. It can increase plasma levels of caffeine, theophylline, pentoxifilin, warfarin, cyclosporin, imetamab, propinirole, clozapine, and even sildenafil. Sildenafil is Viagra. And so the patient might go, oh, that's good, it increases the effect. I like that. Goes to 250 to 500 milligrams twice daily, and maximum of 1.5 grams daily for bone and joint infections, and so on. Metronidazole, I think that's on your list, isn't it? Yeah. Gram-positive and gram-negative, particularly effective against anaerobic organisms that don't require oxygen, so in deep wounds. Common adverse reactions, quite a few. Avoid alcohol during treatment for 24 hours after finishing your course to prevent nausea, vomiting, flushing, headache, and palpitation. That's an extra warning label, and that we should talk to the patient. And if you ask a person, do they drink alcohol? No. Oh, just a slab a day, I don't take much. No problem. People will deny taking alcohol, and that can be quite a big issue. Tetracyclines, you've got one, doxycycline is probably the most common of all the tetracyclines, the safest of them, but it's still got its issues. It's bacteriostatic, inhibits bacterial protein synthesis, a 30th subunit again. Indication, very broad antimicrobial spectrum. MRSA, diabetic foot infection. Contraindications, concomitant vitamin A, retinoids. Children, I've got notice less than 8 or less than 12, because the doctors are saying less than 8, the dentists are saying less than 12, and in the third trimester of pregnancy. Common adverse reaction, nausea, vomiting, diarrhea. These are generally pretty mild. However, photosensitivity may not be. Tetracyclines can serve, particularly doxycycline, can cause and of course it's used in the treatment of prevention of malaria as well, amongst many, many other things. So people go on holidays, take anti-malaria, of course they get imbibe all the sun, they don't put sunblock, and so on. A number of interactions, nothing like the fluoroquinolones. This one I showed, my favourite picture. Okay, counselling, this is tetracycline, naked fluid after food. Do not lie down immediately after taking dose. If it gets stuck in the esophagus, it actually can cause little cancers there, let alone problems.
Yeah, I'll through it.
Yeah, so you need to remain upright, even sitting up in bed. Avoid antacids, iron, etc. That's label 4A, because metallic ions will combine with tetracycline deactivated. So that's label 4A down there. And avoid excessive skin exposure, of course. Otherwise, people tolerate it very well. Just a quick note, COVID-19 antimalarials. I just added this yesterday. Eligibility for COVID-19 medication. They are only, and it varies from state to state, this is Victoria, only for people with COVID-19 who are at higher risk of becoming seriously ill. This includes people at 70 years and over, and those with other medical conditions. So if you're over 70, it's a good chance you'll have another medical condition. So obviously you fit in. 2 products, both available on PBS as of July this year. So that's pretty new. Molnupiravir, although Grego is a trade name, there's only 1 brand at the moment. The capsules, 200 milligrams, 4 capsules, twice a day for 5 days. Very specific time period. Nirmatrelvir in combination with ritonavir, which is an anti-HIV agent. There are many similarities, the pathways. Has many drug interactions. The standard dose of Precautions is 2 150 milligram tablets. So you have two different things here. You've got 2 drugs. You've got this one, single drug. It's effective, but not as effective as nirmatrelvir. And this is 4 capsules, twice a day for 5 days. So relatively simple directions. This one is 2 separate tablets, not combined, physically combined. So you get two separate tablets, and they are taken to different ones. 1 milligram tablet twice a day, and two twice a day. So again, there's a bit of the possibility of getting mixed up. If you're dealing with, say, the nursing home, hopefully the nurses will be administering the drug, hopefully. So to start early in the disease within 5 days. Now, a number of people in my family, my wife and I, have had COVID so far, but my older brother and his wife, they both got it, and they were able to get the drug within a few hours. They rang up, they tested positive, and it made quite a difference. The combination one is more effective, but depending on how severe the symptoms are, I think. Now, this is all new to the doctors as well. It's extremely new for them. But I think you want to keep a watch out for that. Okay, and I think, yes, we have a health plan. Our coffee is made with chicken soup instead of water, and the sprinkles of the donuts are antibiotics. So we're doing well. So thank you.
Thank you, Professor Roller. We appreciate that